Patrick Philus. Hello, everybody. I see that you are more and more to join us. I am just letting the time to everybody to join the webinar before starting. Just to explain you a little bit before we are starting, I will be having the chats open during the whole webinar. So even though we are obviously going to make a question and answer session at the end of the webinar, you can really feel free to ask all your questions during the webinar. So if I am, for example, speaking about a clinical case that you directly have a question that arises in your mind, really feel free to ask it on the chat so I can look at your question and directly answer. Before we are starting, I'd like to first of all thank all of you that are taking time on a Wednesday evening, afternoon, morning for some people, depending on which country you are coming from. You are all, excuse me, you are all coming from more than 43 different countries. The almost 200 people that registered, so from all over the world. I'd like to thank all of you and also thank all our distributors that are promoting our online events. I see someone telling that they are coming from Houston or from the Wisconsin in the US. Please forgive my French accent. I know that on every American city name, there is a special pronunciation that we are not always doing very well as a French person, but let's say it is the little style of the French accent. So first of all, I'd like to especially thank all of you and also remind everybody that there is in only 12 days another lecture that is going to take place online 25th of November from the Dr. Arash Zarampour that is going to present you a full lecture dedicated to the common use of Froggymouth on aligner treatments. It is very important to understand the importance of treating functions, of bringing back functional balance at the end of aligner treatments, and to also know how can you incorporate under optimal way the use of Froggymouth on aligner treatments that are often really processed. That's exactly what Dr. Zarampour is going to show you and explain you in a couple of weeks. So I really welcome as many people that are listening to us tonight to also register for this webinar taking place in a couple of weeks. So now we can finally start, because even though I see that there is not everybody that registered that connected online, as we are saying in France, the late ones are always wrong, so we should start. We're going to present tonight a quick introduction to the use of Froggymouth, starting first of all by reminding some basis about functional rehabilitation to make sure that we are all on the same points at the beginning, understanding the importance of functions. Secondly, I'm going to try to explain you how is the Froggymouth working on the anatomical way, and also show you some results that we were having with the Froggymouth clinical cases and scientific studies. Last but not least, I will show you a protocol showing you one of the way to use the Froggymouth. And if I say one of the way, it's because for me the most important part is the second part where I explain you how is the Froggymouth working. The point of the third part is not to give any cooking recipe that you should just follow like that. No, the point of the second part is to explain you how is the Froggymouth working as a tool, so you can slightly incorporate the use of Froggymouth in your daily use of any techniques that you are used to work with. I see someone that was raising the hands. If you were not there at the beginning of the lecture, as I was saying, if you have any question, feel free to ask it directly on the chat during the webinar. So let's start. We're going to start by saying that everybody now agrees that we should treat functions. But so who are the patients that we should treat with functional therapy? Dysfunctional patients. Of course, there is this kind of dysfunctional patients. I will call it the cliché. He's having an open bite, mouth open, breathing through the mouth, having this posture with the mouth open, black marks under the eyes, clearly the nostrils so close, the typical cliché that he's badly sleeping at night, everything. But is that everything? No, because when we are using Froggymouth, we should not only focus on the most obvious patients that are having all the dysfunctional problems together. Any patient that is having one of those dysfunctions should be considered as dysfunctional patient. That's the three functions that we are going to mainly focus on with the Froggymouth. The wrong tongue posture at rest, the atypical swallowing, which means maintaining primary swallowing after the period where we should naturally transition from primary to secondary swallowing. And last but not least, mouth breathing. All those dysfunctions are composing what we can call the functional matrix or the functional balance. Of course, this is written in French, but it's impossible to translate this document. It's only something very interesting and important that I especially wanted to show you because it's the recommendation made by the high French health authorities that are defining what are the criterion to consider an authentic treatment over. And it is clearly written there that to be over, an authentic treatment require a functional balance to make sure that we are going to have a stable treatment. So we know that any dysfunctional patient should be treated because it requires a functional balance for having a stable authentic results. And that the law is saying we have to, as orthodontists, make sure that every patient finishing his authentic treatment is having a functional balance. No matter the age of the patient, we need that to consider an authentic treatment over. How many patients are actually dysfunctional? Because we were seeing at the beginning the cliché of the little boy that is having absolutely everything. Some studies in the 60s were giving us some primary results. It said that 40% of young patients and 30% of adults were having atypical swallowing, as you can see on the articles quoted in the sources. But that's about the general population. What actually matters for us is the patients. I don't care about the general populations. My question is, how many patients crossing the entrance door of my orthodontic office are dysfunctional? That's the most important question. And that's a question that an article recently published in La Revue d'EDF, as you can see directly the last reference, is answering this question with a result that can sound super high, but that is actually making sense, which is 85% of authentic patients suffer from myofunctional disorders. It's a lot, but it makes sense when we are trying to actually think how many patients are having their deformation that is only having a genetical background. Very, very low. So that's why it totally makes sense that there's so many patients dysfunctional. So we know 85% of patients are actually dysfunctional, that the law, at least in France, says and states that we have to make all patients functional at the end of authentic treatment. And another survey study shows that actually it is very hard for all the French orthodontists. I always speak about France because that's a market I know the most, are having a lot of troubles to find enough myofunctional therapists to treat all their patients. That's what it is stated at the bottom of this horrible graph to read, that there is actually only 1/3 of all the orthodontists that say that they are able to have all their patients treated by myofunctional therapists. And 2/3 of them says that they are not able to find enough myofunctional therapists to treat everybody. 60% of those 2/3 take care of the dysfunctions by themselves, but they are pretty disappointed about the results. And 40% do not do anything for the function, which is terrible and clearly leads the patient to a future relapse. Now that we said that, how are we seeing if one of our patients is dysfunctional or not? There is some symptoms that may lead us to make the proper functional diagnosis. But if I had to only give you one to always keep in mind, it is clearly the contraction of the chin musculature. Let me show you on this patient. This patient is perfectly swallowing. You could see on his neck that he was actually swallowing his saliva, but there's absolutely no contraction at the level of the lips or the chin. Now he's switching. Now it's a bad swallowing, as you can see. How can you see it? Because he requires a lip seal. There is a lip contraction, a chin contraction when he's swallowing. And you can see that there is a clear lip seal right there. If you're having any doubt, or if you want to show to the parents the importance of the dysfunction, you can do this little tricky exercise using the little finger to pull the chin, and not too hard, not like that as he was showing, but just like I'm showing you right now on my camera, just like that, and swallowing. If you're having a patient that has no swallowing problem, it will look like that, like he was showing. No contraction at all. But if you're having a patient that is dysfunctional, that's exactly what you're going to see what this patient is doing right now. The patient needs to make the lip seal, no matter if there is a finger or not. So you are going to see right there the necessity to create a lip seal, and you're going to feel on your finger the pressure of all the face muscle contracting and applying this pressure on the teeth. That's, in my opinion, the best way to observe a dysfunction for the first video, this one. And then for this exercise, the best way to show the parents the importance of what we are doing. Because a lot of time when we are saying to the parents, your child is swallowing saliva in the wrong way. They are saying, really? They are swallowing the wrong way. I have so many problems at home. They are not properly doing their homework. And you are telling me that they are not swallowing their saliva in the right way. No, it looks meaningless for them, and we have to show the parents the importance of the myofunctional therapy to make sure to have a good compliance. So now that we said that, now that we stated so many patients need our help with myofunctional therapy, where is the primary swallowing? Where is the atypical swallowing coming from? We were all of us in primary swallowing when we were looking like this baby. We start our life as a baby in primary swallowing to be able to swallow our saliva, to do the breastfeeding, to chew and swallow food. Because when we are on the first days, first weeks, first month of our life, we are not having teeth. So we are swallowing thanks to the primary swallowing. That's fully normal. That's how we are breastfeeding, for example. Then, when we start to turn 3 years old, 4 years old, patients start to have teeth. And when patients start to have teeth, we need to change our way of swallow. We need to not only swallow thanks to a gap of pressure anymore. We need to stabilize the mandibula thanks to the occlusion. We need to throw the saliva in our throat, not because we are swallowing thanks to a gap of pressure, but thanks to the mechanical movements of the tongue that is doing these peristaltic movements that you can see right there on the video. That is the transition from primary to secondary swallowing that naturally happens when we start to get our first molars. Why molars? Because it is the fact of chewing hard food that is sending to our brain the message that we should change our way of swallowing saliva. Unfortunately, our civilization is not chewing hard enough food, and that's one of the reasons, not the only reason, but one of the reasons why we are having so many children remaining in primary swallowing and so many adults and children that are having deformations because they were not changing the way of swallowing saliva, and we are having all the consequences of a myofunctional imbalance that come with it. So for all those patients, we can propose the Froggymouth. What's the Froggymouth exactly? The Froggymouth is a device that, if we are coming back a little bit before, make impossible the contact between the two lips. Why so? Because when we are in primary swallowing, as we were seeing as a baby, to swallow like that, we need the lip seal. We need to isolate the inside of the mouth from the outside to be able to swallow thanks to gap of pressure. What we do with the Froggymouth is making impossible to create this seal. If there is no seal, there is no swallowing thanks to a gap of pressure. So every time that the patient is trying to swallow his saliva, he's trying to close the teeth, trying to recreate the lip seal, and then not able to. So if the patient is not able to swallow saliva anymore, that there is more and more saliva in the mouth, patients needs to find a solution. And the only solution available is to stabilize the mandibula, not thanks to the muscle contraction anymore, but thanks to the molar occlusion, and not use the gap of pressure to throw the saliva in the throat, but use the peristaltic movement of the tongue. That's exactly what you are forced to do as a patient when you wear the Froggymouth, but not because someone explained you anything, just because you are forced to do so. And also for all the persons that were wondering if maintaining those lips open for 15 minutes per day is having any chance to create something wrong or bad on the breathing, I'd like to directly answer the importance of Froggymouth to also treat the mouth breathing that we are, of course, always all fighting. But our point of view, our target is that the mouth breathing should not only be inhibited by the lip seal, because lips can open during the day. We should use the physiological seal to avoid and inhibit mouth breathing. Why? Because anyone who is breathing naturally through the nose is breathing through the nose no matter if they are having lips open or closed. Why? Because if you have the right tongue posture at rest, you are not breathing through the mouth. Why? Because at rest, the right tongue posture is having its posterior part, the styloglossus, raised in a high posture. And you can directly check on yourself. It fully inhibits the mouth breathing. That's one of the other reasons why you should not only focus on the tip of the tongue. Because if you are only raising the tip of the tongue like that, you can totally breathe through the mouth. But if you are not raising just the tip of the tongue, but if you are focusing on the posterior part of your tongue, the styloglossus, like that, you can have the mouth open or closed. You're always going to be in nose breathing because the natural seal to inhibit the mouth breathing is a high posture of the tongue at rest. So what we said about the Froggymouth before, to be very concrete, Froggymouth has to be worn 15 minutes per day in front of the television. Television is very important to catch the attention of the patients. It's very easy to choose the right size. You should only look at the posture of the lip at rest and make sure that the Froggymouth is not touching the corner of the lips. You having the dimensions of all the different sizes of the Froggymouth. And if you want a little help with the age, of course, we should never choose the size of a Froggymouth according to the age of the patients. But as little indication, for most of the Caucasian populations, the large size is too big. Only patients with an actual big mouth, more or less 10% of the population, needs the large Froggymouth. Then it's only between the small one and the medium one. Usually, the balance age when you are turning from needing the small to the medium one is around 10 years old for boys and 13 years old for girls. But let's keep in mind that what really matters is exactly that. Having a couple of millimeters on each side to make sure that we are not having the Froggymouth touching any corner of the lips. So you wear Froggymouth 15 minutes per day. It's very important to keep in mind that it is only 15 minutes per day in front of the television, as I said, to catch the attention, but also to remain the look, the lingual plane horizontal. If you are in holidays, that you are not having any television available, you should not use it like that. You should raise the level of the screen to be able to make sure that it arrives at the level of the eyes of the patient. Oops. So by doing that, we are making sure that the head of the patient will never be like that and always having an horizontal look to make sure we are not in a posture where saliva is falling. Other very important instructions, never remove the Froggymouth when you are wearing it. No matter if it is to speak, to do anything, you are keeping from the first second to the last second the Froggymouth in the mouth. If the patient remove the Froggymouth at any point, then we need to restart the 15 minutes per day of wearing the device. Then after that, very simple instructions, nothing more than that. That's how is the Froggymouth working at the theoretical level. That's the anatomical philosophy of it. But now let's see how it is actually efficient on patients. First, I'd like to show you some clinical cases. And the first one is, in my opinion, really well showing and expressing the idea of the Froggymouth to inhibit the primary swallowing. This patient is 3 years old, having cerebral palsy, so it is impossible to make him being aware of his tongue posture. 3 years old, cerebral palsy, absolutely no way to have an active way of doing rehabilitation. He was working with myofunctional therapist for 6 months because he was also swallowing in the wrong way, which was putting his health in danger. And they were not able to make him aware of his tongue posture because he's 3 years old and having cerebral palsy. That's why when we start the Froggymouth treatments, we can see that we are really having a patient that is in panic. He knew how to swallow his saliva before, primary swallowing. He's not able anymore to do so. Why? Because he cannot create any lip seal. He's even trying to push his tongue on the gap to fill it, but it's not working. It's not creating a seal. And we see him again 2 weeks later, 14 days later. And what's crazy is that in 2 weeks, without realizing anything, without being aware of what is primary swallowing, what is secondary swallowing, we are having a patient that naturally discovered the secondary swallowing only through feelings and sensation. That's what Froggymouth is actually doing. Not teaching the patient the right way to swallow, but making impossible the wrong way to swallow, to force the patient to discover by themselves a solution to adapt and overcome the obstacle represented by the Froggymouth, and finally figure out what's the secondary swallowing. Once it's done, thanks to this anoetic approach, the brain is directly making the transition to the natural way of swallowing for his age, secondary swallowing. This leads us to have great results on young patients. Why? Because when we are treating young patients, that we are removing the tongue dysfunction, we may have great morphological aspects, orthopedic effects. Why? Because we remove a problem and we use the growth of a young patient to be able to reach an expected outcome. But what's really matter for me to say when I'm showing you an open bite case on young patient, of course, it's thanks to Froggymouth that Dr. Elia Jipa, that I salute if she's listening at us, a wonderful practitioner that you should all follow on social networks because she's doing real great orthodontics, was obtaining these results only by putting a Froggymouth. But it's not the Froggymouth that obtained these results. Froggymouth brought back a functional balance to this patient. And when we are bringing back a functional balance in the patient, we are having a morphological effect if there is still good growth, which is the case on young patients. But I insist on the fact that Froggymouth is a myofunctional device doing myofunctional therapy, bringing back myofunctional balance, and only that. Then it's the functional balance that has an orthodontic orthopedic effect, never the Froggymouth by itself. Of course, open bites are the most commonly deformation associated with wrong tongue posture, because it is very easy to imagine the tongue thrust that is creating the open bite, of course. But the truth is that wrong tongue posture actually creates so many kind of different deformation. And we can see that thanks to the very beautiful case as well of Dr. Stéphane Samama from France that was treating a crossbite patients only with the Froggymouth on 6 months. Once again, by bringing back a functional balance. Once again, it's not Froggymouth that did that. Froggymouth was a tool to treat the tongue dysfunction, and treating the tongue dysfunction was enough to help the patients to go back to good occlusion. But Froggymouth is not at all a device that should only be worn like that alone, with nothing else. I really love always this clinical case of a very young patient that was having a huge class 2 that so many people were saying that would require surgery later. My father was actually only using very simple devices, holy plates with a little plane like that, plus the Froggymouth. And thanks to that, was able to advance the mandibula and save this patient from having surgery later, because between 4 years old and 14 years old, he was not coming back to see my father. He was living his life and coming back at 14 years old. Of course, he's still having a little class 2. And I'm absolutely sure that she will probably need a little aesthetical treatment to have perfect occlusion. But that's not the point of doing myofunctional therapy on young patients. The point is to bring back the growth on the right direction, and then orthodontists should do their job of making all the finishing and making sure that the occlusion is perfect. I take a little bit of time because there was a couple questions on the chat. I don't know if everybody's seeing the chat right now, but the first question was, if the tongue is between the teeth, will this... No, I come back on the open bite treatment because I think that that was the question related. If the tongue is between the teeth, will this device help prevent this malfunction? So to answer directly, if the tongue is between the teeth, for example, in this open bite case, I don't really question myself if the tongue is between the teeth or not. What matters for me is my patient able to swallow saliva or not? I can tell you something. What is making this patient right there able to swallow with the tongue between the teeth is the fact that with the lips, he's creating a lip seal, a clear lip seal. So if I prevent the lip seal, I prevent the swallow thanks to the primary swallowing. I force my patient to swallow with molar occlusion. And when he swallow with molar occlusion, that he cannot anymore swallow thanks to a gap of pressure, he will not be able to keep his tongue between the teeth to swallow. He will need his tongue to make the peristaltic movement to throw the saliva in the back. So the tongue cannot mechanically stay between the teeth for the secondary swallowing that I am teaching to my patients thanks to the Froggymouth. Second question. Bonsoir. If it takes 6 months for a young patient to see improvement, how long will it take for adults? Very good question that I keep on the side because it will be answered a little bit later. What I am showing you in those cases is 6 month delay between patients, because sometimes we are letting 6 months between some appointments, but we're having also way quicker results. For example, this one was having 2 weeks to get the discovery of secondary swallowing. Then the orthodontic effect, it's not my problem. What I do with the Froggymouth is fixing a myofunctional disorder, not expecting an orthodontic result and change after that. This can take a little bit of time, or it can go very quickly, like in this case treated by Dr. Ottavio Fedele. We are in only couple months, we were seeing an upon bite clearly starting to close. It's not yet fully good because there's only 2 months between the two pictures, and it will continue to go on the same direction later. So if the patient, third question, if the patient has muscle weakness, jaw, tongue, would they develop some kind of compensation if we use Froggymouth before we do myofunctional therapy? Yes, they will compensate, and they will compensate on the only way that they are able to compensate wearing the Froggymouth in the mouth. Stabilizing the mandibula by the molar occlusion and swallowing saliva thanks to the peristaltic movement of the tongue. My point when I use the Froggymouth is not to assess any muscle weakness or not. My point is to put my patient into a situation where I am forcing the patient to not use primary swallowing anymore, because this is forcing the brain to adapt and overcome. And the only physiological way that they may find to adapt and overcome is using a way of swallowing that they know deep in their mind, but they were never having any situation forcing them to use this secondary swallowing. That's what I do with the Froggymouth. So fourth question, if the patient is between the teeth, will this device help prevent this malfunction? It's a little bit what I was saying for the first question. My point is not wondering where is the tongue right now for the wrong swallowing. Some primary swallowing are having a tongue thrust projecting anteriorly that is going to create an open bite, for example. But some other patients are having a tongue that goes laterally that will create a deep bite, for example. Some patients have a very, very long, low tongue posture that will create a class 3. Some patients are, because of their primary swallowing, sucking their lower lips like that, which will create a class 2. My point is not to wonder what was the previous wrong tongue posture. My point is to make this previous wrong tongue posture inefficient to force the good one to rise. I take 2 more questions before going through and continuing the presentation. Can Froggymouth be used on patient that has braces? Very important. I just answer you in couple slides. How do you have positive results with class 3 occlusion as well? Clearly, I was showing these class 2 patients, but on the different books of Dr. Phallus and also on the clinical cases that you can see on articles online and on clinical cases on the froggymouth.com website, you can see some class 3 occlusion that clearly improved with the Froggymouth as well. Because all of that, class 2 and all the stuff like that, are used of Froggymouth on young patients. Why on young patients? Because when you do myofunctional therapy on young patients, it is so nice, feeling so good, because you are seeing a big, big effect on the deformation of the patients. Directly, I fix the tongue thrust of an open bite patient. I see this patient couple months later. I have beautiful results that I can be proud of. But how about teenagers? How about adult patients? How about patients with braces, as the question was asked? No problem. No problem at all. Braces, aligner, it's not a problem. I am sorry, the cats do not understand the importance of being in a live session. Sorry, I'm disturbed by this little beauty. So Froggymouth is used with all kinds of braces, aligner treatments, or any orthodontic treatment. The point of Froggymouth, as I was saying, is not at all to be an orthodontic device. The point is to support orthodontic treatments by bringing back myofunctional balance. It's only worn on the lips. That's why you should wear it with braces, with aligner, without any problem at all. For example, if you have an adult patient, we often say it's useless to do myofunctional therapy on adult patients, on teenagers. That's true. You are not going to close this open bite just by removing the tongue thrust. Clearly, you're going to need a mechanical treatment to do that. Clearly. But your mechanical treatment, if you are not fixing the tongue thrust, is useless. You're going to have a relapse. No matter if you are putting a retainer or not, you're going to have a relapse. Clearly. That's why the French health authority are considering that all the orthodontic treatments on young patients, on teenagers, on adults needs a myofunctional balance at the end of the treatment to be considered done and over. As we can see with the last question asked on the chat, I have a 16 years old female patient with a lateral thrust open on the right side. Orthodontist can close it. Will this help, Roxane? First of all, clearly, because fixing the lateral tongue thrust is mandatory to have stable results. Mandatory. If you are not fixing this lateral tongue thrust, the treatment will relapse at some point for sure. Is it enough to only do myofunctional therapy on a 16 years old patient? Clearly not. We need to also have a regular orthodontic treatment to close any deformation that is treated by an orthodontist. So, Froggymouth is a device that you use in addition of an orthodontic treatment. Now that I was showing you some beautiful clinical cases, as I always say, if I want to cheat, I can fail 99% of my cases and only show you the 1% of clinical cases that is successful. Great. It will be beautiful, but it's not very important and interesting for you. For you, what matters is when you are using Froggymouth in large range of patients, what kind of results can you expect? For that, I am recommending all of you to go watch all the literature published about the Froggymouth. Not any articles that you can also check on the Froggymouth website, froggymouth.com, where you are also having a lot of articles written by Dr. Fellus. The point of all those articles is that they are independent study assessing through their own point of view, through different spectrum, the efficiency of the Froggymouth. For example, this university thesis of Dr. Fadani, directed by Professor Gendini, is trying to assess what kinds of anatomical change can we expect when we are having a successful myofunctional therapy with the Froggymouth. For example, by assessing the intercanine distance and what kind of improvement can we expect. I recommend all of you to go watch the study. I also recommend all of you to go read the article of Professor Quincy from Italy and Sabina Sacomano, that is a great therapist working on myofunctional therapy, that is assessing two stuff. The increase of lip strength we can expect with the Froggymouth, as I was saying earlier, a question about muscle strength or muscle weaknesses. And this study clearly showed on 33 children that we are having a clear increase on the lip strength. And additionally, the study is assessing over 6 months what's the amount of success rate that we can expect by using the Froggymouth. And they are arriving on 80% of success rate over 6 months. But what's an actual success when we speak about myofunctional therapy? I even prefer this study because it is differentiating two kinds of success. The first kind of success is when we are having our patients able to swallow properly. We ask our patient to swallow, they do it in the right way. Wonderful. But the fact that they are able to do it, does that mean that they are doing it all day long? Does that mean that they are also doing that when they are hanging out with their friends, for example? No, clearly not. That's a big difference between engram stage 1 and automation. So what I love about this study is that it makes the difference between the engram and the automation. Also, most of the time when we are using those kind of devices, we are mixing a little bit of the active and passive approach. The passive approach is the Froggymouth, making impossible the wrong swallowing, forcing the patient to discover by themselves the good swallowing. And the active therapy is explaining the patients what we are expecting from them. And when you do both, active plus passive, you are obviously giving the most chances to your patient to be re-educated at the end of the treatment, but it's very difficult to know what's the part that you owe to the passive therapy and what's the part that you owe to the active therapy. That's why on this study, they decided to only do passive therapy, not doing any additional exercises. Just putting the Froggymouth in the mouth of patients and seeing how it goes after 5 weeks and how it goes after 10 weeks. The first step that we are noticing is that after 5 weeks, surprisingly, there is more than one patient out of two that was still not discovering secondary swallowing by themselves. But it's not at all a problem because after 10 weeks, 2.5 months, 80% of patients were discovering secondary swallowing by themselves. And 3/4 of those 80%, so 60% of the total, has reached the automation, which means that they are using the right swallowing program, no matter when they are assessed, not. It was the first study made in France in 2016, but it was confirmed by a more recent study that we are really grateful to the doctor Natalia that did it, that that maybe is going to present you directly the result of her study in a future webinar, but I do not spoil that already. That was reproducing a very similar study on 85 patients instead of 40 patients, splitting them into 3 different age groups. What we can see is a very great but not that surprising results. First of all, we're having almost exactly the same results as the previous study. Failure for between 60 and 50% after 5 weeks when we are not adding any other exercises. And after 10 weeks, only between 17 and 19, 20% here of patients that stayed at stage 0. More or less 80% has discovered secondary swallowing, and more or less 3/4 of those patients have naturally transitioned to an automated secondary swallowing. That's exactly what we are expecting from our patients. Wonderful. This is showing you what you can expect by the use of Froggymouth on 10 weeks on patients that actually wear the device. Great. It's great as a statistician, but now as a clinician, you don't want 60%, you don't want 80%, you want to be as close as possible to the 100%. So right now, what we're going to focus on is those 17% that are still stuck at stage 0? Is the 14% that are stuck at stage 1, having a gram the secondary swallowing, but not automated it yet? That's why I'm going to present you a little step-by-step protocol that you can follow, not exactly like that, but just adapt to your use of myofunctional therapy in your daily way of working in your office. First of all, show the device when you make the diagnosis of a dysfunctional patient. You show them the brochure, you show them eventually some informational videos that are on our YouTube channel, and you put the Froggymouth on the mouth of the patients, making sure they wear it properly, which means having lips inside and only the lips, not having the teeth inside like many patients do. And then you assess, is my patient directly adapting to this new anatomical environment where primary swallowing isn't possible anymore? Is the engram happening spontaneously, directly, or not? If yes, it's wonderful. Treatment will be so easy. If not, most of the case, just give one instruction, put the teeth in occlusion. Of course, you can just let the patients figure out everything by themselves, but you can also give little hints, some points, like asking the patient to put the teeth in occlusion. Then you ask the patient to go back home, and when you are seeing him again coming back, every time, at every further appointment, you ask the patient to always bring the Froggymouth with him or with her, and every time to wear the Froggymouth in front of you. You can directly see if the patient is wearing it often enough or not, and swallow the saliva with the Froggymouth, and also without the Froggymouth, to be able to assess the engram. Is the engram happening after 1 week, after 2 weeks, after 5 weeks, after 7 or 8 weeks sometimes? There is no clear schedule. When should you consider that now the patient should have discovered primary swallowing? It's really up to you and up to how often are you seeing your patients. That's it. If at some point you think it's too long for the patient to engram, you can help the patients by putting the patients on the right path by doing the tongue wrestling exercise. You take a mirror or just a pen and you ask the patient to fight your pen, your mirror, with the tongue. You apply pressure on the styloglus, the posterior part of the tongue, and you say to your patient, hey, try to put my mirror and to press it, to crush it on the palate. It sounds nothing, but the truth is that it is exactly making the patients elevating the styloglossus, creating the motor image of the styloglossus elevation that you are expecting from your patients. After that, give again the Froggymouth to the patients, and almost all patients, almost all of them, will be able to swallow in secondary swallowing after that. Now you should only work on automation. And be careful, when you work in automation, you need to assess the automation in the right way. When you're having your patient like that, that is on the dentist chair or on the speech therapist chair, you are not assessing the automation. The patient is aware of being assessed. Right there, when you are coming to the waiting room to ask your patient to join you, you can look at the actual habits of the patients. That's why it's so important to try to observe the patients when he's not thinking to be observed. If you have any doubt, you can use the speech exercise. Because the point to assess automation is to assess the tongue when it is working as usual, not when it is taking care of its own position. Speaking is great for that. Because when you speak, you are not thinking about your tongue posture. And you can directly assess when a patient is speaking Where is the tongue? Is the tongue interposing between dental arches or not? If yes, there is no automation. If the patient's tongue is staying inside its box and not interfering at any point, neither anteriorly nor posteriorly, you can consider that you are getting closer and closer to automation. And what's wonderful with this exercise is that you can also use it as an exercise to help to reach the automation. Ask the patient to count like that with teeth closed. You can also ask the patient to clench the teeth between every numbers that you are asking the patient to count. Count 1 to 20 and clench the teeth between every number. That's a wonderful type of exercise to help the patient to reach automation. But there's so many different kinds of other exercises. So many. The point is not to tell you should do that or that. No. The point is to tell you adapt and incorporate Froggymouth in your daily way of doing your job, doing your therapy, doing your treatments. Just use the Froggymouth to be able to have your patient reaching a functional balance by adding or without adding additional active exercise. But maintain the Froggymouth until reaching the automation. And when you see a patient that automated all the good functions, progressively remove the Froggymouth by decreasing the amount of days per week where they are wearing it. 4 days a week, 3 days a week, etc. And then you can release your patients in the nature with good functions. The patient will have better sleep and so many positive outcomes will come after that. So just to summarize, you have a lot of tools online on our YouTube channel, including 16 hours of replays of webinars, lectures from so many different practitioners from more than 12 countries all over the world, more than 10 different specialties, just honestly sharing what is their way of treating patients with the Froggymouth. That's what you are having available on our YouTube channel, translated into 4 different languages. So now I will just take some question and answer, but before finishing everything, for the ones that have to leave right now, I really remind you and recommend you to attend the webinar of Dr. Zarampour that will take place in a couple of weeks on the same place right here in Zoom. You can now ask me all your questions on the chat. So, if Froggymouth make tongue change for swallowing, will we see improvement in speech as well? For example, in interdental lisps. Having wrong tongue posture clearly impacts negatively the speech, clearly. What Froggymouth is doing is to fix the wrong tongue posture. So if the wrong tongue posture was having a bad effect on the speech, it will fix this bad effect. There is some other speech problems that are not linked to the tongue posture, and on that, we will have no impact. So that's why I insist that much on the fact that Froggymouth is really a device that is and only doing bringing back myofunctional balance. Then all the further potential positive aspects, they are coming from the functional balance. For example, closing an open bite. Froggymouth do not close any open bite. Froggymouth do not fix any cross bites. Froggymouth fix tongue posture, bring back a functional balance, and the functional balance can, depending on the causes of the deformation, close an open bite, fix a cross bite, fix a speech problem, for example. Other question, from how many years can a froggy be worn? The froggy can be worn, first of all, from any age, but it starts to be useful at an age where the patient should have naturally transitioned to secondary swallowing. I see no problem to put that on a 1 year old patient, but I see no point at all in doing that. The patient is having a physiological primary swallowing. Froggymouth is an inhibitor of the primary swallowing. It's not a device that wonder is the primary swallowing physiological right now or not. No, it inhibits primary swallowing. When you consider as therapists that primary swallowing isn't physiological anymore, you can start using the Froggymouth. More or less, it's 3 years old, the moment when we may start to use the Froggymouth. Yet to miss the first part of the presentation is the way we can hear it again. You will get this answer directly here by Daria or on the chat as well. And this is very informative. I have several patients that are going to that I'm going to start with this. Thank you so much, Sign Roxanne. Thank you very much, Roxanne, for this beautiful feedback. And I have to say that Roxane is a very famous character of a French theater piece that many of you probably know under the name of Cyrano de Bergerac. That is a beautiful name that is creating a lot of emotions for all the French people that thinks about Cyrano de Bergerac. I thank you for your thank you messages. Let me know if you have any further clinical question. Thank you, Anita, for the feedback. So, should use of Froggymouth be followed by orthodontist? Can it be followed by speech therapist? Can be followed by both, clearly. The point of the Froggymouth is once again to fix a myofunctional disorder. Some orthodontists want to take care of myofunctional disorder by themselves, as we were showing in the beginning of the lecture, because on some places, they don't want or they are not having myofunctional therapist available next to them. Myofunctional therapist wants, or speech therapist wants to bring back a functional balance and can use and follow a Froggymouth treatment. Both orthodontists and speech therapists may and should collaborate into a transdisciplinary approach to get the best chance for the patient to be properly rehabilitated with automated functional balance at the end. That's what we promote. And in this situation, the Froggymouth should be followed by the orthodontist and the speech therapist together in cooperation. When it's possible, we are always promoting the transdisciplinary approach. Froggymouth bring quick results on the patients that are easy to rehabilitate. And then older myofunctional therapists or speech therapists can spend more time on the patients that needs the most, a customized approach to have customized exercise depending on their needs. That's why Froggymouth is so interesting. Also for the speech therapists that already know and have already great results on myofunctional therapy. For the question about the certificate to prove that you had followed the webinar, I unfortunately don't think that we have certificates for that, but you can always send a message to contact@Froggymouth. Oh no, Daria was saying that you can actually have a certificate. Sorry, my bad. Just by sending a message at contact@Froggymouth.com. Good question of Florentina Lostun. Does it help in parafunction, such as clenching or bruxism? It's a little bit the same question as for if it helped for the speech. Many bruxism problem or clenching problems are highly linked with a myofunctional imbalance. Bringing back functional balance clearly help that. There's other kinds of bruxism that is linked to other situations, stress, for example. Clearly and unfortunately, we are not going to reduce the stress with the Froggymouth, and so bruxism caused by that, it will not help. Bruxism caused by a wrong tongue posture and a wrong breathing pattern, it will clearly help. Is there any questions left? For all of you who might still have questions left, I recommend you to send the questions to contact@froggymouth.com. We are always paying attention and making sure that all questions of practitioners and users are always answered. For all the practitioners that are interested on the common protocols on how to use aligners and Froggymouth together, I really recommend you to participate to the next webinar, November 25th with Dr. Zarampo. I thank you so much, everybody that followed this webinar. Feel free to send more questions to the Froggymouth team, and we are thanking you for the time that you took on your day to follow us and listen about the Froggymouth. Thank you very much, everybody, and we will see each other in the next Froggymouth webinar.